degree of uncertainty.
And the uncertainty would be approximately 50%?
Yeah, I think that's not an unreasonable assumption, but it is an assumption on the part of Dr. Ornelas.
And in the event that we had 50% less than the 0.3, that still keeps us in the shadow range, doesn't it?
Yeah, it would be on the simulation about 1 milligram, which is at least 10 times higher than, or approximately 10 times higher than what was measured.
And the measured amount is this line that goes right across the bottom.
Yes, sir.
So whether it's 0.3, 0.2, 0.25, you still have a much higher urine concentration than what was found at time of autopsy, if the scenario was a 3-hour infusion started by Dr. Schaefer, or as indicated a possibility by Dr. Schaefer.
Yes.
And also, is there anything else that's inconsistent with this model by Dr. Schaefer with respect to, was there lidocaine used?
Well, in recalling Dr. Schaefer's report, it was a little confusing, but my reading of the report, I think you have a copy of it, but suggested that propofol and lidocaine can be mixed together. I have to say, as a clinician, I've never mixed lidocaine with propofol for an infusion, because we typically give lidocaine, which is a local anesthetic. Mr. Jackson referred to it as anti-burn, I believe. But you administer that either with propofol or by itself into the intravenous just before you start propofol, because propofol, one of its most common side effects is intense burning. And this burning is influenced by many factors: the concentration, the speed of injection, and most importantly, the size of the vein. And when you're putting IV cannulas into very small veins, as was the case for Mr. Jackson because he had no larger veins, the burning is intense. So you have to assume with this model that lidocaine would have been given just prior to 9 o'clock. And I think Dr. Schaefer gave 2 scenarios. One where he added 10 cc's to the 100 ml vial that you saw. But again, that's a glass vial, and I don't think physically it's possible to inject 10 cc's of lidocaine into that vial to mix it up, because you would have 110 mLs in this glass vial, and if you look at it, it's pretty much full with just the propofol. So I think what he then assumed was that Dr. Murray had drawn up a 1-to-1 mixture of lidocaine and propofol. And I think that Dr. Schaefer said in his report that was consistent with the levels. That is 50 milligrams of propofol, 5 cc's, drawn up with 5 cc's or 50 milligrams of lidocaine to fill up that 10 cc syringe that I showed you. If you gave even if you gave 25 milligrams or even 50 milligrams, that is, if you gave the whole syringe prior to starting this infusion, my estimate, based on the known short half-life, that is the time at which it takes for the lidocaine level to fall in the blood after a bolus injection, there would be virtually no lidocaine present at 12 or thereabouts when Mr. Jackson was dead, and you would expect, therefore, to have virtually no measurable lidocaine in the blood at the time of autopsy. And as I recall, there was a level of about 0.84 micrograms per mil. Is that correct?
You're talking about the autopsy results?
Yes.
0.84?
0.84 micrograms per mil lidocaine.
So in the event, in this scenario, you gave any lidocaine whatsoever, it would be at the beginning of the infusion.
That's the only reason we would give lidocaine. I can't conceive of a reason for just giving a bolus of lidocaine during an infusion when a patient's sleeping.
You would not give lidocaine once the infusion has started and the patient is sedated. Is that correct?
That's correct, unless the patient was, for some bizarre reason or some unusual reason, complaining of a lot of pain at the injection site, which would actually suggest that the IV may be, call it, infiltrated or not flowing properly.
Or if perhaps if the patient woke up and you had to, would you give lidocaine to to increase the infusion?
Possibly, not typically. When we're doing sedation with these type of infusions, which is what I described as modern anesthesia care, we typically, if we need to give a little bolus of propofol to get them to a little deeper sedation, we don't commonly give additional lidocaine at that point, because it's normally if they're having pain, it's just when you start with the first injection for anesthesia or for sedation. And once you're beyond that period of time, usually the pain in the IV site is not a problem.
So what you're saying is in this model here, or this scenario, the lidocaine would be given at about 9 o'clock, and whether it's 2.5 cc's or whether it's 5 cc's, you'd expect it to be gone out of the system at 12.
I would, yes.
And so that wouldn't account for the 0.84 that was discovered at autopsy.
Correct.
On the scenario that involves the two uses of propofol, the 25 milligram slow push over 3 to 5 minutes shown here, that would have been accompanied by lidocaine. Is that correct?
Yes, there would have been a transient increase in the lidocaine level. Given its half-life, the curve would probably look somewhat similar to the curve that Dr. Schaefer produced for us and is illustrated on this graph, on the upper part of the graph.
And lidocaine would have been given also at the 1040, 1050, whenever this dose, the rapid bolus dose was given also. Is that correct?
Yeah, the lidocaine curve would then, of course, not be so smooth, or the little peak there would be more peaked. It would be similar in shape to the propofol curve, perhaps a little lower, and because the concentrations are a little different.
And as we have toxicology results at time of autopsy, 0.84 lidocaine, would that correspond with the amount of lidocaine you'd expect to still remain once this bolus injection was given?
I believe it's fairly close to what was found at the time of autopsy in the femoral blood, yes. And
this urine scenario that goes along the bottom here, if this is also based upon Simon's 0.3% measurement?
Yes, it is.
If you knocked it down to 2.5, would you get something that's very close?
Well, you'd get a lower number, but again, as I pointed out, this scale for the unchanged propofol is a very expanded scale. So it would be lower, unquestionably. It would probably drop down the second curve after the second bolus to a level that's at or slightly below the dashed line. Again, I just want to emphasize that the dashed line is a measured, quantifiable concentration of free propofol in the urine. And the other lines, the models are simulations, and again, subject to all the variability that I've tried to explain over the last 4 days. And they only give you a visual of what could have occurred, but again, I would caution not to attach yourself to the specific values. The fact that they're not zero, though, is important, that they're actually measurable drug present.
And once again, this line takes into consideration by the dashed line above and below the solid red line, takes into consideration a plus or minus 50% variation?
Yes, 50% degree of uncertainty.
And that uncertainty can take the 0.3 all the way down to a 0.15, couldn't it?
Yes, it could.
On another subject, We've spent a lot of time talking about standard of care. Is there a
Yes, we
difference? Is there a difference between standard of care and standard of actual practice?
Yes, I mean, standard of care is the ideal. It's what we would seek for every patient. But there are many circumstances, and I indicated a few, where it's not necessarily possible or it's not common to actually have the highest possible level with respect to guidelines that are generated by distinguished organizations. Committees come up with these guidelines. Some are not based on evidence. Some clearly are important for patient care. But I could give you examples if you want.
Well, give me an example.
Of where the standard of care may not be the standard of practice. We talked yesterday about a whole list of monitoring approaches that would ideally be used every time a patient receives a sedative infusion or multiple doses of a potent intravenous drug for sedation or anesthesia, and that would be capnography. Capnography is used to measure end-tidal CO2, which is what we exhale. And as I mentioned, when we have a tracheal tube in during anesthesia, we can very precisely measure the CO2 in the lungs. But when you're using a catheter device to measure CO2 at the nose or in the mouth, there's gas coming in, room air diluting it, and it's not always reliable. Also, if the patient snores or is a mouth breather and you have the cannula in the nose, you won't detect appropriate CO2 values because you have to be moving air. So although I think it is a useful monitor, I mean, when we developed the sedation techniques back in the early 80s when I was at Stanford, we used to put a cannula through nasal prongs. We'd actually put a little IV cannula just so we could hook it up to our capnograph machine. Capnograph is the device that's used to measure CO2, carbon dioxide. I'm sorry, I didn't say that. So it's something that we'd like to have, but it's in many situations where propofol is given in plastic surgeons' offices, in GI clinics, in other venues apart from an operating room, it's simply not used.
And
another example would be, for example, an infusion. Okay.
The objection is sustained.
Sorry.
Everything starting with, and another example is stricken. Disregard that. Thank you. Mr. Flanagan?
when we ended the other day talking about the 100 milliliter infusion, talked about on this diagram prepared by Dr. Schaefer, you indicated that it was not reasonable because it didn't correspond with Dr. Murray's statement, it didn't match up with the urine test expectations at time of autopsy, and there was no physical evidence at the scene that would support this. Do you now also include the fact that lidocaine would have been used at the beginning of the infusion and would result in a near zero lidocaine level at noon?
That is my opinion, yes.
What exhibit, please?
Exhibit quadruple S. Talked a little bit yesterday about minimal sedation, moderate sedation, and the standards of the ASA House of Delegates put down on October 27, 2004. Now, this minimal is...
Could you expand a little bit? It's tough to see.
Okay.
Thank you.
Where it says minimal sedation anxiolysis, what is anxiolysis?
Well, as I stated yesterday, anxiolysis is reduction or prevention of anxiety
Now,
or
how
nervousness.
do you relieve anxiety?
You give anxiolytic drugs that have the potential to reduce anxiety. For example, benzodiazepines propofol, and various